Hello, my name's Alex Wickham, and I am a consultant anaesthetist at St Mary's Hospital, part of Imperial College Healthcare in London. And I'm going to talk to you about major trauma. And I've been asked to talk specifically about UK practice and some guidelines. Um, Let me just move on the slide. The button's not there. So thank you very much for asking me to talk. It's very nice to be asked. By way of introduction, I'm an anaesthetist. I do major trauma at St Mary's Hospital, as well as some vascular and esophagogastric work. And when I'm not clinical, I have some academic roles supervising trauma-related projects at various academic institutions in London. And through my own stupidity, I have been a trauma patient on several occasions. Today, I am going to talk to you about acute management of trauma. I'm going to give an overview of damage control and talk to you about pain management in the trauma patient. And it will be a sort of, I'm going to focus on what we do as well as how we use the guidelines. And at the end, there is some guideline resources available for you, and I'll tell you how to access those. So first things first is standardization of process. So we have a standard setup in our ED resus with anesthetic machines, the same as we have in theatre. We have drawers laid out exactly the same with the same drugs, the same airway equipment, and pre-prepared boxes of anesthetic drugs. With adult general anesthetic drugs, pediatric general anesthetic drugs, and resuscitation drugs, so that we've got the same kit and we're familiar with it and we use the same thing over and over. And we will get a standardized information alert from the pre-hospital team, whether it be the ambulance service or, as in this case, London's Air Ambulance or HEMS. So this patient, 20-year-old man, has had several stab wounds, and you can see that he is physiologically compromised. They are unable to record a blood pressure and have only a weak radial pulse, and that he is intoxicated with a reduced GCS. Or is he intoxicated? Possibly he is. This is part of his physiological compromise. So from that, we would start preparing for blood transfusion, potentially for rapid transit to theatre. When the patient arrives, we encourage everybody to be quiet for the handover, because otherwise things get missed. And before we perhaps even take handover, we would ask the team whether any immediate intervention is required, such as management of exsanguination or any airway compromise. But it's really key that the whole team listens to the APMIST handover, because people who are not will distract the people who are. But everybody has something to give in these injuries for these patients. Slide's not moving. That's right. So you'll all be aware of the A to E approach advocated by ATLS, and that advocates for sequential management. However, we will do A to E as a team. There will be one person dedicated to the primary survey, but multiple interventions will be happening at the same time. So whilst A to E is happening, monitoring will be going on, vascular access will be sought, and ample history will be being taken. And that will take us just a couple of minutes so that we can move very quickly from there to further interventions. And the A to E approach in ATLS will give you all sorts of symptoms to look for and signs to look for. But these 8 items would identify a critically unwell, physiologically compromised trauma patient. So one with air hunger, tachypnea, with collapsed veins, who's hypotensive, perhaps with a reduced end-tidal carbon dioxide, if it's being monitored at this point. Those with tachycardia, bradycardia, those with altered mental status, or who appear anxious and frightened when perhaps they weren't initially, and the sweaty, pale patient, coined as the hateful 8. These identify somebody who is at imminent risk of dying as a result of their trauma. Once you've received the patient, it's likely that we'll be going for CT scan or getting imaging to identify the injuries, and CT has a number needed to treat of around about 25 to 30, I think. So it is key, if you can get there, to plan surgery. But If you can't, then you can go straight to one of the intervention suites at St Mary's, or you might go there after CT scan. But pictured here on top left is Theatre 8, with all the kit that we have in our major trauma theatre. And this trauma theatre lays fallow, ready to receive major trauma patients 24/7. And we also sometimes go to the interventional radiology suite, perhaps for isolated penetrating injuries, or pelvic fractures, for example, where we can intervene and prevent further bleeding. With airway management, we need to consider where we manage the airway. So it might be that for humanitarian reasons or airway compromise, we need to do it in the emergency department or even pre-hospital. But if you can, doing it in the operating theatre, where there is somebody, a surgeon, able to manage the physiological compromise, would be ideal. Before we induce, we use a modified WHO checklist in code red exsanguinating trauma patients or people who are taken straight to theatre. And it's the joint responsibility of the person leading the trauma team as well as the anaesthetist to ensure that this is done. And it basically merges the sign-in and time-out components of the WHO checklist, but it makes sure we've got the right person and that the whole team is talking before we actually proceed. We use manual and stabilization if it's needed. We don't if it's an isolated penetrating injury, but if blunt trauma, then we would. And it's applied from the foot end by a suitably skilled person, but not one of the airway team. And we'll pre-oxygenate thoroughly, and I would include high flow oxygen therapy en route from the emergency department to theatre as part of that. Cricoid was very popular in the UK. I think it is still relatively widely practiced, perhaps more so than in other parts of the world. But we are moving away from it because of the effects that it has on airway anatomy and ease of intubation, as well as particularly if applied over-enthusiastically, and the two-handed nature that's provided in cervical spine management. We advocate for video laryngoscopy at first pass, with or without hyperangulated blade, particularly in C-spine patients, C-spine injury patients, to improve first pass success and also to help the team support the airway management so that everybody's confident the tube has gone down the right hole. And some advocate use of bougie for first pass. I don't when I've got a skilled laryngoscopist present, but in the pre-hospital or an adverse austere environment, it might be wise to consider. And we also strongly advocate for single lumen endotracheal tubes, even if the chest is going to be opened, because of the complexities of double lumen tubes. And if you are not familiar with them or using them regularly, they can cause more harm than good, particularly when you've got multiple other things to consider at the time, such as physiological compromise and blood management and team management. Single lumen tube with a bronchial blocker is adequate for what we need. In terms of induction, as you are aware, anaesthesia causes physiological compromise, further compounding the patient who's being brought that of the patient who's being brought acutely to theatre for management of their traumatic injuries. We advocate fentanyl, ketamine, and rocuranium as the ideal drugs for induction. The oft advocated 3 micrograms per kilogram, 2 milligrams per kilogram of ketamine, 1 milligram per kilogram of rocuranium needs to be titrated to volume state. The patient's injury, their physiology as a result of that injury, their age and frailty, and their pre-operative GCS, such that it might be wise in certain patient groups to significantly reduce and perhaps just give small doses of ketamine and rocuranium. And I teach people to titrate it to effect, just to loss of voice, response to a verbal stimulus, because you can always give more. And if you give a pre-planned bolus, you risk significant physiological compromise. And you should give concurrent blood and volume at the time of induction to account for the vasodilation, and have vasopressors to hand, but they shouldn't be used as a first line for the bleeding patient for reasons that I will go into later. If you don't titrate to the patient's physiology or to their potential physiology after induction, you get a situation such as recorded here after induction. So this person had what looks like a 3-2-1 induction, quite a large dose of fentanyl, a reasonable dose of ketamine, assuming the patient's about 70 kilos, and then rock uranium, they've just given the whole syringe. But you can see that that has caused significant physiological compromise, even though they were giving some red blood cells at the time. And they've had to elevate the legs and give compressions and more blood products. And perhaps I would argue that this could be avoided with a slightly more judicious and titrated dose of drugs, and a slower approach to induction. Once you have induced, maintaining anesthesia, we need a low MAC, and you can of volatile if you're using that. I don't advocate TIVA at all for these patients, but you could use perhaps continued bolus of ketamine and titrate as tolerated to the surgery and stimulus and physiology. Ventilation, initially we limit intrathoracic pressure to avoid collapsing the small vessels on after the right side of the heart. We use a high FI2, a lower respiratory rate and lower PEEPs, and then once the bleeding has been stopped and physiology is being restored, we then start to wean oxygen, build tidal volumes and restore lung protective ventilation as able. And we give small boluses, small aliquots of titrated multimodal analgesia. And you can see a graph here. The patient's blood pressure is starting to increase with volume filling, and that's the point at which you can give a small bolus of fentanyl, for example, 25 or 50 mics, and you'll see a drop in the pressure. And then you can give some more filling, bring that up, and so on and so forth, until you start getting less physiological compromise as a result of the sympathetic block caused by fentanyl, and you start restoring blood pressure towards normality. Now we're going to talk about, that was a bit about the sort of anesthetic management. I'm going to talk about the overall management of the patient and damage control resuscitation. This concept comes from the military, or the Navy in particular, where damaged ships, the principle was to get it back to port so you didn't lose hugely expensive asset and all the people on board. So you did what you needed to make the ship mobile and able to get back to port. And the aim is the same with critically ill trauma patients. It's the balance between doing the definitive operation, which is what you ideally want to do, and doing just enough to get them through this day to the intensive care unit so that physiology can be restored, so that they can go back to theatre and have their definitive operation later on. Who do we do it in? Well, if you've got a patient who responds to resuscitation, then operate, do the definitive repair. However, if there's a progressive deterioration or they're not responding to resuscitation, then this is the point to start damage control principles. And you could do that at any point during the operation. You can just say, we can't, we're keeping up, we're fine, and then they're not. So then you start damage control and you do what is necessary to get the patient to the intensive care unit, and they come back for have their physiology restored and come back for the definitive reoperation. But damage control shouldn't be done for all trauma patients because it isn't without harm and isn't without resource implications. So for the patients who need it, it's the right thing, but it's not the right thing for everybody. Who is it right for? This sort of patient, the patient who is significantly hypothermic, acidemic, who has had a large transfusion requirement or has evidence of coagulopathy. These are the sort of patients that might need it. And it consists of three principles. There's the surgical aspect, there's the hemostatic resuscitation aspect, and then there's permissive hypotension. And some of these areas are controversial, particularly the permissive hypotension, and subject to ongoing research. Damage control surgery consists of 4 elements: stopping the bleeding, controlling any sepsis, removing any dead or significantly contaminated tissue, protecting the patient from any further injuries, and then temporary closure. It should take no more than 1 hour. It's quick surgery. And these are the sort of things that they might be doing. So the patient should be positioned in the crucifix position. We need a major laparotomy and vascular set, as well as thoracotomy equipment, a cell salvage applied, as well as 20 to 40 large abdominal packs, ready counted, ready to use. When they open the abdomen, they will pack around the liver, the spleen, the kidneys, and in the pelvis, and compress the organs. And they will press, and they will wait. and then they will sequentially remove them and identify the bleeding source and control it where possible. For damage control thoracotomy, some of our cardiothoracic colleagues with the relevant kit will do a median stenotomy. However, our trauma surgeons will do a bilateral anterior thoracotomy or clamshell thoracotomy because, as you can see, it gives you excellent exposure of the lungs and the heart and allows you to manage injuries of the lungs or staple areas off, or do stapled or pleated repairs of bleeding cardiac injuries. And you can see here excellent exposure of the lungs, both inflating nicely, and you can see a sutured repair of an injury to the heart just here from a stab wound in London relatively recently. Whilst the surgeons are doing their bit, we are mindful of the hemostatic resuscitation goals. So that is the rapid and effective restoration of blood volume to treat and manage and prevent, to a degree, the acute coagulopathy of trauma. And it's important to do sort of four things to maintain the functional blood composition of the blood. So that means its ability to clot, its ability to carry oxygen, to provide blood pressure, and also to maintain the biochemistry. And as an overview, these are the sort of things that we do. We limit crystalloids as far as possible, and I'll come on to why in a second. We follow a major hemorrhage protocol for the institution. Now, all four London major trauma centres have a very similar major hemorrhage protocol, so it's standardised care. And this is starts out with a balanced transfusion of 1:1:1 ratios after the proper trial. So 1 of red, 1 of FFP to 1 of platelets. And in practice, that means 4 units of red cells to 4 units of FFP to 1 pool of platelets, which contains 4 to 6. We will often also start drawing up fibrinogen concentrate so that we can, rather than waiting for cryoprecipitate, which takes 40 minutes to thaw and then a little bit longer to come from the lab, we've got pre-prepared vials of fibrinogen concentrate, so we can start giving that early on. But we'll rapidly move from this balanced transfusion ratio to that targeted and personalized to the patient by arterial blood gas and viscoelastic assays. We use TEG at St Mary's, but other hospitals in London have ROTEM. I think most of us use TEG though. And this gives us a graph, so you will be aware of the sort of wine glass analogies, as well as the numbers. And we've built our with our hematology and blood transfusion labs the major hemorrhage and blood product guidelines into the program, so that out of hours, or for people who don't manage hemorrhage regularly, the information is there. It tells you what to do and makes it simple. So when you're managing multiple things, not only do our trainees and colleagues know what to do, but the lab can also see this, and they can start preparing products based on what we might ask for. And we will then use point of care guided transfusion, broadly keeping to the 1:1:1 ratios, but perhaps targeting elements of fibrinogen or platelets where necessary. We'll give 2 grams of tranexamic acid. It might be that 2nd gram is not given as an infusion, rather given as a bolus. And we'll give calcium chloride, roughly 10 millimoles, in titrated aliquots, roughly per one syringe of 10 millimoles per 4 bags of red cells. We may give bicarbonate, and often we end up needing insulin and dextrose in larger transfusions to account for the hyperkalemia that can happen if older blood is being used. We'll reverse any anticoagulation using standard pathways, and we will have a very low threshold for using cell salvage, which is hugely beneficial for these patients in reducing transfusion requirements. From a practical perspective, 2 to 14 to 16 gauge cannulae is often enough, but we will obtain central large bore access on some occasions. So we use a trauma line, which is a very short 8.5 French arrow rapid infusion cannula. We need to suture it in, and then we attach a Belmont to it, or the 14 gauge. And through those devices, you can get flow rates of up to 750 mils a minute, which is certainly faster than most of the transfusion systems that the rest of the hospital provides can deliver. So we can keep up with blood loss very quickly, and it also warms. We will aggressively warm the patient, so any exposed area will be covered with either Gamgee or incontinence pads, but they will be covered, and we will have 2 bear huggers, one over, one under, to maintain and warm. And we will use arterial lines, but we wouldn't insist on one being inserted before moving from the emergency department or to theatre. We would use non-invasive blood pressure and get the arterial line in later on, when we had tasks, possibly after induction, for example, because it takes time to do. There is no such thing as a quick arterial line once all the setup factors have been considered. From a human factors perspective, it's important to assign roles. So I often see myself as, I often stood back trying to keep my hands free, and I have somebody running the anaesthetic, somebody doing drugs, somebody as a blood monitor, and a rapid infuser operator. So you can see at top right here, I have Sam, who's one of my old SHOs, running the level 1, as it was some time ago, and we'd roped in a neurosurgeon and one of the ED nurses to check blood products, so that we had enough people to do the various jobs that were needed. Moving forward, you can see with advances in technology, the Belmont is much easier to run. So I've got Hugh, one of my registrars here, on the phone to the blood bank and doing both blood bank liaison and rapid infusion management. And they would be aware of what we have given thus far. So where are we with the ratios? What do we actually physically have available in theatre to give? And what have we requested? What are the blood bank preparing for us? And we make sure that we request in advance, because the blood lab at St Mary's is in a different building, and it takes even the most energetic, enthusiastic porter approximately 14 minutes to do the round trip. So we need to be thinking ahead so that we've got blood products coming. And as you can see in the picture at the bottom, it's drapes down anaesthesia, so we can see what the surgeons are doing and we can talk to them easily, because we want to keep up with what they're doing. And you can see here a couple of acronyms for that prompt conversations. So at St Mary's, we've got Snapchat. At the Royal London, they use BASED, but you can see they both identify the same sort of things. What's the surgical progress? How many blood products have been transfused? What's the physiology like? What's the ABG, temperature and TEG looking like? And what are you going to do next? What are the anaesthetic team going to do next? What are the surgeons going to do next? Because this is very much physiological surgery delivered by a team. And if you don't do this, if you don't talk to your surgeons, you put the barriers up, it will lead to adverse outcomes because you're not working in sync. In terms of monitoring and targets, we use physiological markers on the arterial blood gas rather than the hemoglobin, which is unreliable in the acute hemorrhage, as you know. We use viscoelastic assays as well as the rate of ongoing blood loss. And there are some targets here from the Oxford Handbook of Anaesthesia, which I won't dwell on, but this will be available as a PDF for you to review and obviously to watch. Permissive hypertension, I'm only going to touch on briefly in the interest of time, but it's a temporarily tolerated process rather than a goal in itself. It's like a means to an end, because aggressively attempting to normalize the blood pressure with vasopressors or crystalloids seems to be counterproductive, because crystalloids will cause a dilutional coagulopathy as well as anemia. They're bad for the endovascular, the vascular endothelium, and therefore detrimental. If some patient's bleeding, we should give blood. And vasopressors in the hypovolemic patient risks arrhythmias, they risk increased cardiac work, reducing tissue perfusion, and increasing blood loss and bleeding duration. They can, however, be used once the bleeding has been stopped, you've caught up with the volume, it can start be introduced as the depth of anaesthesia and analgesia is increased. And I've got some targets here as sort of rough rules of thumb. In the awake patient, conscious level is, if they're conscious, that's their blood pressure is sufficient. Because we assume that they are they're auto-regulating appropriately. There are some suggested lower limits here based on coronary and cerebral blood pressure circulations. But remember, these are population values, and applying it to your patient, the patient in front of you, is important. They may have impaired autoregulation as a result of disease or as a result of injury, particularly in head injury. In cases where you've got bleeding as well as brain or spinal cord injury, you'll see that the recommended thresholds for systolic pressures are slightly higher. Moving on now from damage control resuscitation to pain management, which is the other thing that we often get involved with as anaesthetists in trauma. So this is an overview. You know the importance of assessing pain and looking for the different types of pain and giving balanced multimodal analgesia and using guidance and tailoring that guidance to the individual and then regularly reviewing and titrating, and the importance of a little bit of kindness and staff education is key, as well as patient education and patient goal setting, expectation setting. So as healthcare professionals, generally, as far as pain is concerned, particularly in the trauma setting, we're pretty good at tolerating the pain of others. And I would ask you to reflect on that a little bit. These numbers are quite old, but significant number of patients are in pain when they present with trauma, as you would expect, but pain management delayed by up to an hour to 90 minutes, and pain present most of the time, all or most of the time, in a third, with insufficient analgesia in just under a half of patients. And you can accuse me of this data being, a lot of it being old, but this data isn't old. It's from 2018 to 21 in the UK, just prior to or peri-COVID, and they looked at over 100,000 significantly injured patients, of whom 50,000 patients had the adequate data. And you can see that the median time from arrival in the emergency department to adequate analgesia was 90 minutes. 70% of patients didn't get an opioid, either in the pre-hospital or the emergency department. And the people who got the worst pain management were those who are typically disadvantaged for various reasons of health inequality in the UK anyway, the elderly and women. Head injuries, we're often taught that head injuries don't hurt. If you look at a variety of sort of anaesthetic exam related literature, there is this notion that head injuries don't hurt as much, and I suppose there's also the worry about compounding GCS and difficulties assessing the patient, but they often get minimal analgesia. But happily, consultant presence reduces time to analgesia. And you can see from my own experience here, this is me, age 27, with a fractured tibia. I got 4 milligrams of morphine as a 27-year-old, 85-kilo rugby-playing man, and have also had a chest injury stitched up as an 11-year-old without local anaesthetic, with the reason given above. So I have first-hand experience of our ability to tolerate the pain of others, and I would suggest that we all reflect on this hard. There isn't actually that much guidance or evidence base specifically for the polytrauma patient. I always come back to this article from 2009 because I haven't found that many updates since then, but we can extrapolate from other areas. For example, this comparison table from the Faculty of Pain Medicine on the Royal College of Anaesthetists website, which shows ibuprofen and paracetamol being the most effective, with a number needed to treat of less than 2. There's the World Health Organization ladder, analgesic ladder, which we can extrapolate from the outpatient cancer setting, turn it on its head, rather than working up it, working down it. So that initially we start with all of the analgesics and then we wean them down as the patient's pain improves. Certain injuries lend themselves really nicely to protocolized pathways of care. For example, rib fractures, traumatic amputation, burns type pain. We can, in the case of rib injuries, we have a well-established rib injury pathway at St Mary's. We stratify all of our patients using the Stumble score. We get early effective analgesia into these patients. We start regular pain assessments. We get early physiotherapy and rehabilitation. We teach them how to do active cycle breathing technique rapidly, and we cohort them for nursing expertise on our major trauma ward. When I say early aggressive pain management, this is what I mean. I mean an anaesthetic registrar or consultant or anaesthetist inserting a block within hours of the patient's arrival. This man had fallen down an escalator and had broken 9 ribs. And here he is getting a rectus spinae plane block in the emergency department within an hour of CT diagnosis. We have a block bag, which is just an old transfer bag with all of the kit and guidelines in it that you might need for regional anaesthesia and for so that we don't have to go hunting for the kit. It just cuts down time and makes us mobile. So we will go and put in blocks wherever the patient is, provided there is a monitor next to their bed so that they can do it safely. So we'll do it in intensive care, we'll do it in the emergency department, we'll also do it in theatres as well. When we think about pain management as anaesthetists, typically we're thinking about it in the perioperative period, where a patient has one surgically induced injury, whether it be a laparotomy, a hernia repair, a laparoscopy port site injury, or a limb injury. But polytrauma patients will have lots of injuries, and so we need to think a little bit about what we do. And it might be that they need a block for one element, that's the worst element, as well as PCA or opioids and other drugs for other areas of their body which are also sore. And these are some of the things that we can use to manage these patients. Regional anaesthesia, I know you're going to have a talk from Madan Narayan of Fribly Healthcare, who is excellent. So I'm not going to dwell on this, but there are lots and lots of targets, all of which can be facilitated by ultrasound. I've got a picture here of the cross-section through the chest wall, and you can see at least 6 targets there for rib fracture analgesia. We advocate for catheters where possible, and use have various programs on our pumps to manage to deliver local anaesthetic. But we cohort these patients on our surgical wards, and 2 or 3 surgical wards, so that we can monitor for side effects and ensure we're not causing risking compartment syndrome, etc., and local anaesthetic toxicity. We do have some tips and pointers that we give to our trainees. So often most UK-based trainees will be exposed to regional anaesthesia and epidural neuraxial analgesia, particularly on the labour ward, where we'll use MEFIX to cover the catheters, but with leaving perhaps a small window, or we might use locket devices to keep things in place. However, whilst that works really nicely for the clean obstetric patient who's going to have an epidural for a few hours or 24, 48 hours, it's not great when you're putting an epidural in for somebody with rib fractures, or a block in for somebody with significant limb trauma. Because the locket causes skin to sweat, and it's a perfect breeding ground for bugs and catheter-related infections, as well as pressure area damage. So we advocate just using Tegaderm or a clear, transparent dressing, so that the insertion site and only tunneling sites can be used. And this is I fix the catheter and filter assembly onto the patient's arm, so to reduce the risk of inadvertent disconnections at this point. And it just keeps it all nice and steady. You can see this is actually a esophagectomy patient, but the principal holds, and I do the same for my trauma patients. We also advocate tunneling epidurals or blocks, so they can stay in for longer. We teach our trainees using the simple model of a banana. And there's nice evidence from this study in Germany. This registry study from 2018 showed that tunneling the epidurals and also peripheral infections reduce the risk of catheter-related infections. And where you do start seeing catheter-related infection, it's very important to monitor the patient and remove the block, treat their pain in a different mechanism, and then keep a close eye on it thereafter. Because even though the block has been removed, or the catheter has been removed, there are still potential for the infection to reach important sites such as the central nervous system thereafter. We have a very low threshold for anti-neuropathics based on colleagues' experience from working in Camp Bastion in Afghanistan, where neuropathic pain was assumed from the start in major injuries. And you can see an injury such as this on the left, where a London bus has gone over somebody's legs. You would expect there to be neuropathic pain. However, what is interesting from the COPET study, which is in write-up, and also the WIS study, is that elements of neuropathic pain are there in most lower limb trauma patients, and if you search for them, can be found in a variety of trauma patients where the nerve is in close proximity to the bone. So if you don't search for it, you won't find it, but it won't respond to standard analgesics, and is worth looking for. We have a relatively low threshold for using ketamine as an analgesic at Imperial after a trial where we give either 1 or 2 milligram, 2.5 milligram bolus, separated by up to 5 minutes each. If the patient has a nice response, then we'll start them on oral ketamine 25 to 50 milligrams, either 3 to 4 times daily, or an IV infusion if they're not absorbing. And that's really nice in reducing the need for a PCA with minimal side effects at these low doses, and it can be useful as an adjunct to wean patients off higher doses of opioids. It's important also to minimize the nocebo effects, and a lot of what I've been talking about you're probably familiar with, but this has been written about more recently in the medical literature. So the placebo effect you will all know of, but the nocebo effect is the expectation of negative effects about a treatment that increases the chances that someone will feel them. So where somebody expects an intervention to be painful, for example, cannulation, they will get more pain from that. Where they expect paracetamol, for example, to be ineffective, which is often said to me by my patients, they will get less analgesia for that given treatment. Now, I'm still going to give it to them, but if those expectations are sought and managed, and the positive effects of paracetamol emphasized without the and although the negative effects of any drug need to be mentioned, but perhaps not overly stressed, then you can get more effect from the drug that you're going to give anyway. And you should give analgesia openly. So show the patient you're giving them a variety of different analgesic effects and educate them about those benefits. And they will get more benefit from analgesia. And you can see more about this from the works by Mike Siner, which is in the portfolio of information that I've provided for you at the end of this talk. So there's a variety of elements that of resources that you can access. So this is from NHS England. There's the ATAC manual, and then this Centre for Trauma Sciences has all of the London Trauma System guidelines on it. This talk will be available as a PDF. This bit of the presentation is actually a clickable link. So if you click on it, it will take you to that website and all of those guidelines. Thank you very much for listening. So as a reminder for Anaesthesia for Trauma, although we standardize elements of the care, one size doesn't fit all, and you should personalize everything to your patient. It's important in the early stages, particularly to maintain forward momentum, to take care at induction and apply damage control resuscitation principles, but you don't need to use it for every single patient thereafter. Make sure you get the analgesia in rapidly, and please do look after yourselves when looking after these sick patients. Thank you very much for listening. There is a QR code here for your mobile phones. You can point them at it. It will take you to a Dropbox folder with a variety of selected guidelines and relevant articles. And if you wish to get in contact with me, my email address and Twitter handle are there. Once again, thank you very much for listening, and I hope you found it beneficial.